So I'm going to get us started and then we'll continue to let people join on in. It is wonderful to have you here to join us in the 5th of 6 cafes in the future of care for children with medical complexity. This one is health equity and anti-ableism through family partnership. Arguably one of the most important cafes we have in the series. And our discussants today are Nikki Montgomery and Michelle White, and we are so grateful for them being here. Next slide, please. So this is generously funded and with great thought partnership with the Lucille Packard Foundation for Children's Health. And I do have to say that this project is being partnered. Also, it's myself and Meg Camo, who is here today and will be monitoring chat and chiming in with anything she may have to share, and she'll be helping with breakouts. We all have a cadre of people here today to support, but I especially want to thank Meg for her partnership. Next slide, please. So this series, just to orient you, we're really looking to foster interdisciplinary dialogue, and we want to look at meaningful systems improvements for CMC. So we really focus that, as you'll see, 25 minutes is breakouts. We do have some presentation and then some share it at the end. And family partners are co-leading in every session. They're co-facilitators, they're presenters, they're family faculty that help us to hone and make sure that we're pulling out what's most important and elevating priorities from everything that you say. And these are all analyzed with an interdisciplinary faculty, which is majority of which are families. Next slide, please. So we are truly interdisciplinary. The folks on the top are more highly represented, but we have all these people that sit in different parts of the system here today. And about a tie are public health and policy and family, youth, and leaders, and not too far behind are CMC providers, all sitting at around 35 to 50 people that have registered today. And then we get social work and the others and in good number too. Next slide, please. So please feel free to raise your hand. Please feel free to chat as well. Everything is just as important, and we capture it in the synthesis, no matter what way you share it, including registration questions before, and including what you may share in evaluation after if you've had additional thoughts. Next slide, please. And you can see here all the wonderful things you can do with Zoom. If you want to stay muted, please. And we'd love for you to be on camera because we'd love to see each other and for the vitality of the discussion. Next slide, please. I also want to share and be very excited to share out with you that we have one of the cafes, Cafe 4. I just realized that I want to put the link in, and I did not have opened the proper document to be able to do that. So I'm going to open it right now, and in just a moment, I'll put that link in once I'm done talking, because I can't do two things at once. So this is a fantastic graphic, and Meg just gave kudos to Karina from ConverSketch, who creates these graphics from our conversations. And this is now available on our website from Cafe 4, and we hope that you will check it out. And we will certainly have more coming forward, and including more thematic synthesis. You've already seen Cafe 1's thematic synthesis. Cafe 2 is coming out that has the key highlights in a very digestible and engaging format. So that's coming. Those will be coming from each cafe. Next slide, please. Today's topic, we wanted to give some guidelines to support respectful dialogue, recognizing that it's just can be sensitive for people. So this is, we're doing this today for so many reasons, but it was such a huge theme from the CMC coin, which this series is predicated upon, that families of CMC experience pervasive bias for themselves and with their child. And it's been the underpinning of each and every cafe and in the discussion materials, and recognizing that family partnership they are saying family partnership is essential in order to do something to mitigate this. That's the only way. This can sometimes be emotionally charged, it's sensitive. So we want to really focus here, just kind of have everyone return to listening with curiosity and care, assume best intentions. Someone's saying something that feels to you that it's not hitting right. assume best intentions, and we all want to take advantage of our time together to consider how we can individually and collectively address bias and potential harm across disciplines and perspectives. And we want to try to look at tangible ways that we can do that, because it feels much better when you feel like you're like, okay, what can I do? Okay, next slide, please. So now I'm going to hand it on over to Nikki Montgomery. You can read her and Michelle's bios online on the website, which I will also put in the chat in just a moment once I get to doing my links. And thank you. Take it away, Nikki.
Thanks, Bethlyn. So I want to start us off. I'm a former English teacher, so I just like to start with definitions so we're all sharing the same concepts and understanding how we're looking at a topic or an idea. There are many definitions for each of the terms that you see here on this screen, but I'm going to give some simplified ones just to kind of frame our conversation today. So I'm going to start in the middle at ableism, because that's one of the topics that we said we'd discuss today. So ableism is really negative beliefs about disability, which can lead to discrimination and bias. And often healthcare settings can accidentally be ableist in that it can be looking at disability as something to fix versus understanding that disability is a different human condition. And so there can be roots of ableism that still show up in healthcare a lot. Next, I'll go to racism. Oh, sorry, classism. I'll go to classism next because that one just moved. Classism, you may hear it as like discrimination based on socioeconomic status. And so just looking at people in terms of what money they might make and what ideas we could have about them based on where they are socioeconomically is classism. And next, I will talk about racism. Thank you. Racism is prejudice or discrimination based on race or ethnicity, including the idea that some ethnic groups are inferior or superior. And so that's the basic idea behind racism. Next, I will add linguistic bias. Linguistic bias is really a set of beliefs about people based on the language they speak or how they speak. And that can be beliefs about their intelligence or their capacity based on language. And then finally here I have sexism, and that is discrimination based on gender, and gender identity can be included here. There are also many isms that are not included here. So I just want to say that I didn't capture them all. That circle would have been really convoluted, and it already is pretty complicated, but there are lots of isms, there are lots of phobias, homophobia, xenophobia, lots of different kinds of discriminatory beliefs that people can have about the ways other people are experiencing the world. And so it's not all captured here. I just want to hold that. And then finally, can you click one more time, Mitra? There we go, intersectionality. And so the idea of intersectionality is that some people are experiencing lots of isms at once. So the folks who are experiencing the crossover and the layering of all those isms have a highly different experience than people who are experiencing just one or two. Those can be layered on and can impact the healthcare experience and how people move through the world. So the point here is that ableism does not exist in isolation. It can often be layered on with other isms, and it's really important to keep that in mind as we approach ableism, that we can't approach it in a vacuum, that it often exists in combination. And these isms all together contribute to bias and discrimination that people have and feel in their experiences, and those all contribute to worse outcomes. So that is the reason it's important for our conversation. If we're talking about improving outcomes for children with medical complexity, we have to look at how all of these things intersect and impact their lives. Next slide, please. So I wanted to talk a little bit about how people respond to the bias they experience in the healthcare setting. And there's a couple of terms here that I want, well, one term here in particular that I want to explain, but also that there is a response. So stereotype threat is a type of psychological response. It's a pressure people feel when they know what stereotypes exist for the group that they belong to. So if you belong to a group that experiences stereotypes about your intellect, you might come into the healthcare setting trying to prove that you are smart. If you belong to a group that experiences stereotypes about class, then you may want to come in and prove that you are worthy or socioeconomically sound or all of these different things. So it's almost an added pressure or work that people feel to prove they're not what they understand people might often believe they are. And people with multiple identities often work that much harder to make sure that they're not being stereotyped in settings where they believe they might be discriminated against. So that's stereotype threat, just one concept that people have, and it adds the mental load that people are carrying into the healthcare setting. In addition, you might have a lack of trust, and stereotype threat kind of is a lack of trust, right? I don't trust I'm not going to be discriminated against, so I have to be on guard. But then when we talk about building trust with communities that haven't been served well in healthcare, bias in healthcare can certainly contribute to losing trust. I think that a lot of times the lack of trust in healthcare is pinned on like the Tuskegee experiments and things that happened decades ago. It's really in the day to day that people are experiencing now that they lose trust in healthcare. And so those are not past events or historical events. Those are very current events that happen in people's lives that diminish their trust. And then finally, one of the results is that people can avoid the healthcare setting altogether. And we know for the population we're talking about, that can be harmful, dangerous, it can be life-threatening, et cetera, to avoid healthcare, but sometimes it is safer and smarter to avoid a situation that is harmful. And so recognizing that sometimes when we think of non-compliance and people not returning for appointments and things like that, we like to pin that on the patient and family, but sometimes the experience they're having is the reason they're avoiding the healthcare setting. Next slide, please. Okay, this is a point that I want to rest on because I think it's supremely important. Dealing with bias is not about building character. And I think that sometimes approaching implicit bias, learning about our biases, et cetera, it's like, yeah, we're going to be a better person. And that's the approach that's taken. But it is life threatening to experience bias. And so I think we need to be thinking of it as a safety issue. A lot of times people will say, well, I've dealt with my biases, I'm great. And so that kind of signaling like I'm good can do more harm because we're not checking in on where we really are. And I think it's important to just kind of have that humility to say, maybe I'm not good. Let me check in. Let me make sure my bias is not leading how I'm approaching a situation. For many patients, we know bias is life or death. And the stats we see about maternal and infant mortality, for example, show us that bias is life or death. Intersectional identities, including medical complexity, can be impacted by bias in very life or death ways. So I would like for us to pull out of thinking it's character building and to push into thinking this is a safety issue for patients and families. Okay, next slide. And so how do we deal with that? To me, really partnering with families is one of those key ways that we can do that. Here on this slide, I have a few different points: to humanize, to listen, and to co-create. And so first, in that one-to-one interaction, if we're engaging with families at a very human level, we're listening, we're understanding who they are and building relationships, that helps people to be humanized so your bias doesn't necessarily take over. We all have biases, it's natural, but how do we set that to the side by building relationship? Next, when we're engaging families at the community level in work that helps to inform what we do, we want to listen to what those perspectives are and make sure we're hearing a number of different voices and not privileging some voices over others. So being equitable in the way that we engage families offers opportunity to deal with the biases we might not realize or coming into the work we do. And then finally, at that systems level, helping to make sure that diverse perspectives come into the way we create policies, we design practices and processes. All of that means we have an opportunity to mitigate bias by having multiple people at the table and voices at the table who can offer different perspectives. So just wanted to lay out that baseline of information at how we can approach this as we go into our conversations today. Thank you.
Thank you so much, Nikki. It was a pleasure hearing you so clearly articulate some very clear and important pillars to health equity. I'm going to keep going with talking about bias and some things that we can do on the individual and the systems level. First, starting with the individual level, a very important element here that's important to confronting bias is just admitting that you have it. We all have bias. I've been in situations as a Black physician where people have assumed that I'm not biased just because I'm part of a group that is marginalized. And that's not true. I have the same biases or different variations of biases as lots of other folks do. I think the worst thing that you can do is just accept it and do nothing about it. So here are some suggestions for addressing bias, and I hope that this will be a good catalyst for further conversation in our breakout rooms and in our Q&A session. The first thing is to be curious and ask questions. I think this sounds like such a basic thing. And so I'm a pediatrician, obviously, and this is something that kids do really, really well. And we could learn from them and how they ask questions about things. So be curious, ask questions, especially in situations where you might feel uncomfortable. So that leads to the next situation. Who do I feel most comfortable around and why? We all have a psychological tendency called homophily to gravitate toward people who are like us. So thinking about why do I feel more comfortable around this group versus another group and why can be a beginning step toward confronting our own biases. And then who do I feel less comfortable around and why? Similarly, asking yourself about kind of why you feel the way that you do, which kind of goes back to that being curious. Then this is a hard one, but I really encourage everyone to try to do this. Surround yourself with people with different life experiences than you have. This can be just incredibly educational for you. Our society right now is very much structured in such a way that we probably have to try to do this because we are in neighborhoods with people with similar socioeconomic statuses, similar language. You know, you really have to make an effort sometimes, depending on where you live, to be able to do this. But this can be this is a very important element of trying to mitigate the biases that we all carry. Another thing that I try to think about as a pediatrician, especially when I walk in a room or I'm having a conversation with a parent and maybe it doesn't go so well, when you experience a strong emotion or you think there's like an intuition, you really need to take time to ask yourself why, particularly that intuition piece. Because sometimes bias can masquerade itself as intuition, like I got a feeling. Sometimes the feeling that you've got is not the wisest choice and not the most equitable choice. So really taking the time to interrogate your intuitions can be very, very important. And then I say here, even better, talk it over with someone who you can trust. I am very blessed to have coworkers and people in my family that I can talk to about issues, including my own bias or my concern for, am I being biased in this situation? Am I seeing this the right way, or am I so blinded by, you know, even something such as my past experiences that I'm not seeing it in the proper way and I'm not using good judgment? And then the other piece is being humble. If you hear nothing else that I say today about confronting bias on an individual level, please hear this, that humility is important. Making sure that we, again, recognize the biases that we have and that we have people that we can discuss them with, and that we're not just kind of scooting it under the rug, never to be addressed. It's important to just recognize that, when you're wrong, you be able to confront that and deal with that, and when you have bias similarly. Next slide. So on the systems level, some variations of the same strategies. So again, be curious and ask questions. Some of us are in hierarchical positions, where we might be dealing with systems that are biased, but it's kind of above our pay grade. One of the best tools that I've used for dealing with bias from people that are hierarchically above me is to ask questions, because it's less confrontational and it kind of forces them sometimes to say, maybe that's not the best thing in the world. So question can be a very, very powerful tool. Family and patient engagement, and Nikki covered this more beautifully than I will, but always think, who's not at the table but should be? Another key strategy is thinking about if you are in any sort of innovation or intervention, which hopefully all of you are working to create some sort of change in your structures and groups. Are all children benefiting equally from a program or innovation? This question can be very, very powerful because there's this assumption sometimes that a rising tide just naturally lifts all boats. Like if I create this thing, if I create, this was going to help everyone. But the evidence simply doesn't support that. Often we need processes that are tailored to specific groups in order to achieve equity. And then thinking about, as you have an intervention, how do I know what tweaks I might need to make, really assessing the equity of the program. And if you are unable to do that yourself, hiring someone or getting someone to help, a third party can often be really helpful to help adjudicate whether a program is equitable or not. Engage someone with experience in health equity. That is a very, very important tool, particularly since all of us are busy and we kind of have our lanes. It's important to try to partner with those who specifically focus in health equity, if appropriate to the situation. But also in doing so, be aware of identity taxation. There isn't a tendency that I've seen and experienced many times to kind of grab the underrepresented person that you may work with, or someone who is from a marginalized identity. That may not be appropriate. So just be aware of the fact that those individuals tend to be recruited more frequently for certain things than other groups, particularly for DEI activities. Be cognizant of the fact that they should be compensated, that needs to be something that you have a conversation with them about whether or not they're truly comfortable providing their time and expertise and what kind of compensation they might need in order to provide their expertise. Address a big problem with small steps. There's a tendency that I've also seen to kind of look at big problems like racism or ableism and just say, oh my gosh, it's just so big. But it can be conquered with taking small steps. So not to be overawed by the difficulty of the situation, but to recognize that we each have our own parts to play to address the various isms. And then partnering with other disciplines. I will also amend this to include the fact that other disciplines means families as well. Everyone has an expertise and a perspective. And if we can really truly partner with those individuals, we can achieve great things. Next slide. So I did want to include a case here, and we'll have some cases in our breakout rooms as well. This is a case from a year or so ago where I want to highlight harm from bias, and I want to use the child welfare system, which does a lot of good, but does disproportionately affect certain families with certain characteristics. I'm just going to read this case for you, and we can also talk about it during our Q&A. So this is the case. The hospital is full. I'm a hospitalist. I do inpatient medicines. This is like very real for me. You are encouraged to discharge patients as soon as possible. So real. While reviewing your patients before rounds, you read about a patient transferred out of the ICU overnight to your team. The patient is a 7-year-old female, has a history of asthma, and she's been admitted multiple times over the prior 2 years. Later on during rounds, you examine her and you found out she's ready for discharge. And then after you leave the room, a member of the care team walks up to you to suggest that you make a report to CPS because the patient is not attending her pulmonary appointments. Next slide. Later, you call the patient's mother and learn she lives about an hour from the pulmonary clinic. She has multiple children and works full time. She tries to attend appointments with her child, but if she misses one, the next opening is usually 3 to 4 months away. So I include this case to illustrate some of the strategies that I just mentioned in terms of confronting bias. In hearing this case, you could just make the CPS referral, and that may be appropriate. But using a bit of curiosity to call the patient's mom to inquire as to kind of what's been going on. I also, in this case, talked to the pulmonary attending as well, just to get a better understanding of what was going on. Because so often the things that we think of as neglect, or we're kind of blaming the parent, is just wholly incorrect. And once we get a more holistic view of all the things that are going on, we often find out that even if we were put in that parent's place, we wouldn't be able to do anything different because they are facing barriers that are quite systemic and not at all related on the individual level. Next slide. And this case also goes to highlight, although I didn't put the race of the patient in the case, that Black parents and caregivers are disproportionately represented in the child welfare system. And this is due to interpersonal and structural racism. Parents with lower socioeconomic status are also more likely to be involved in the child welfare system due to bias against them, as Nikki pointed out, as well as the stressors and pressures of food and housing insecurity and being unable to access your subspecialty appointments, perhaps because you don't have transportation. So just being very cognizant of the fact that the child welfare system, while it does a lot of good, there are groups that are disproportionately represented in that system. Next slide. So here are just some recommended resources. I'm a researcher, so I've got to put some paper citations on there. I haven't really done a talk for you all to, if you're interested in looking at later on. Next slide. So I think now we'll transition to any questions or comments from our presentations. Thank you so much for your time.
Thank you, Michelle and Nikki. We wanted to first see if anyone had any comments in the main room. We're doing breakouts a little differently, where we're going to have a few cases in the breakouts. And Michelle and Nikki, you'll each breakout will get one case from either Michelle or Nikki that will help to lean into the questions and think things through. We thought that concrete would be a little easier than abstract. So I am going to just wanted to see first, does anyone have questions for either Nikki or Michelle before we go into the breakouts? Meg was asking in the chat, one thing I wrestle with is the hierarchy of disability, how some kinds of diagnoses feel more acceptable and have less inherent bias associated with them than others. So, for example, diagnoses associated with social stigma. Does anyone else experience this, and how do you deal with or tackle it?
Yes, 100%. When I read this, I actually just listened to a lecture on POTS, postural orthostatic tachycardia syndrome, which has a stigma attached to it. People often think that the patient is just has mental illness and just needs to go elsewhere. That's one of many diagnoses that we could cite here. And I think the first thing that I do in this situation is really to recognize the bias and the inherent bias, the tendency to blame the patient. I also do obesity research. So obesity is, of course, one of these. We blame the child or the adult for the weight. And so, yeah, I think the first thing to do is to really recognize the bias and advocate for that individual. You know, especially if they're unable to advocate for themselves, you know, recognizing that that other people who are part of the team or even part of the child's family, you know, may have these biases, and to really try to advocate for a holistic approach to what's going on. Nikki, I don't know if you have any other responses to that.
I would add that the idea of invisible or apparent and visible disability can be a source of bias as well. I'm just going to think of it from an early childhood perspective, is if your child has autism and it is not visible to people, then they assume that the parent is not doing a good job as a parent. Whereas my child's disability is quite visible. He uses a wheelchair. People seem to understand that, but they also tend to have a lower expectation of what his capacity is because he uses a wheelchair. And so I do think that it is complicated and it's not super simple to just parse it all out, but that can be another element of disability that complicates things when we're in a healthcare setting in particular.
Thank you both.
I also see here some things in the chat. Agreed, even within the same diagnosis, some high, some low. Patients with mental illness are dismissed as crazy. FASD versus autism support is what we're dealing with where I practice. Assumptions of disability or diagnosis symptoms. There's a bunch of things coming up. Also, parents of children with mental health diagnoses are often blamed as being bad parents. And then it exists in the community as well. DD and ID are not looked on the same way as wheelchair users, and it can create real barriers for independent living. So that if you look at creators from the different intersectionalities other than yourself, you start to see where some of that plays out. That's a fantastic point. There are more messages here. Yeah, if you have an acronym you'd like to know more about, please make sure to let us know. Assumptions of quality of life. These are fantastic points. I'd really love us to have some time. We're about 5 minutes behind, but not behind because we're exactly where we needed to be. Please continue to throw things into the chat. I'm just going to put a reminder of guidelines for the breakouts. And I do have, we're going to open the breakouts now and just remind you that what we're trying to do here is help us to think about together collectively, making the connections around through these cases of what's at play and how we as individuals can think about the factors, and then really trying to then level up to systems, the structures, and how do we start to look at structures and policies and things that might be driving some of what we're seeing happening, and the bias that underpins that and how we shift it. And we will indeed share the chat feed. We'll pull out from that as well. Okay, wonderful. So we're going to open the breakout rooms. We're going to have until 4:50 to be in breakout rooms together. And so we don't have a ton of time, but let's go to it. And thank you everybody for your patience while we're doing the key highlights. Take it away, Adenike.
Sure, if I can find my mute button here. Thank you. So I just had a couple of questions for the co-facilitators. Shauna, Carolyn, Ann, did you have any key takeaways, and who wanted to go first? Just 1 to 2 minutes.
I can share.
Thanks.
Yeah, our group had some really great conversations, especially around the list of all the biases that we saw within our scenario. And I thought one of the really profound things that Stephanie mentioned was that, why was it with this scenario that a mom without a G-tube, without a child with a G-tube, doesn't need to have an order to make a change to their food diet, but yet a mom of a child with a G-tube does, like just that in itself. And we talked about some strategies, which something as simple as helping families to develop their voice for advocacy. And then on the flip side of that, the conversation went around to why is it that the family has to be the one to fix these concerns with the biases? Why is it the family that's needing to take that extra mile to fix it? So I just thought, some really great conversations around systemic strategies as well as our own individual strategies on what we can do.
Thank you for sharing. I really appreciate that. Carolyn, Anna, either one of you would like to?
Hey, it's
So
Anna.
go
You
ahead.
can go ahead, Carolyn.
So our group looked at case number 1, and I know Bethlyn has put the cases in the chat. Our group talked about a number of things related to the different kinds of biases that were present in this particular scenario that we were looking at. One of the things that we talked about was how this family would really benefit, and many families in these situations would benefit from having a care plan that describes protocols and that the family can actively use. Then another thing that I thought was really helpful that was brought up was the idea of training for all staff at all levels. And also another issue that was brought up in the whole scenario was just about the fact that there needs to be more awareness about trauma-informed care. So those were some of the highlights that I think our group talked about, that healthcare settings need to have systems in place for all of these things, not only language equity, but disability equity as well.
Thank
This
you.
is Anna. Sorry about that. So yeah, we've touched on a variety of things. One of them is that, you know, mothers naturally want to feed their children, and we also had case number 2. And in that, of course, all mothers want to feed their children food that is not contaminated. And so if the provider or the dietitian experienced one incident where food was contaminated, you know, does it mean making a blanket statement where every other parent can't be recommended a home blended diet because of that? And we talked about how this is part of shared decision making, and does the staff really understand that concept and how to put it into action? We talked about collecting information regarding patient experiences and how that might drive making changes to this idea that, you know, food's going to be contaminated. And then we also touched on appointments can feel rushed, and so there might not be space to be curious and to ask questions and get more information. And that with children with medical complexity, you know, everything is medicalized. And maybe we need to step back from that, because we're talking about food here, and we're talking about something so basic that happens in the home and would happen in the home anyway. Why is it different for a child with a feeding tube? Thanks.
Thank you all for sharing. Those are really great points. I want to make sure that I'm being mindful of time. Our group, we pretty much were on board. We had case number 1. So there are a lot of takeaways. I know there'll be a recording, but I know Bethlyn needs a little time to finish up this. So Bethlyn, are you ready, or did you want me to continue?
You go ahead and do your takeaway. I'm going to put a few things in the chat and you
Okay.
carry on.
Okay, so one of the takeaways was we were looking at the situation, wondering, was it bias, or was there a lack of training? And we know there's a lack of training for the case number 1, but there could have been just a lack of training and a lack of communication, and it could be opposite bias, where the person who came in to do the blood draw had cultural differences and ethnic differences. A lot of times in the hospitals and clinic setting, providers are taught to come in, or support providers are taught to come in and just do the work, not have conversations, you know, they may not have even known that the child was nonverbal. So that may have not even been a factor. I think that was a different, in addition to the takeaways that Carolyn shared, that was something that was a little different that I wanted to make sure that we talked about, because it was very important. Training, all of the other things, we're all on board with that. So.
Thank you. That was fantastic points. So thank you, everybody, all around. I think that part of what we try to do here is get us rolling and thinking and getting to start, kind of spark where we need to go. We never have enough time to get really fully into it, but we will. We so appreciate the opportunity. Please, we have one more cafe, and we would love you to be able to be a part of that. If you have any other takeaways, please put them into the chat, because we do truly pull everything together to create a synthesized kind of key highlights document that we can then share out with everybody, and that includes the resources as part of this. So please share that, and an evaluation that you see there. If you have anything further that comes to mind, you can throw that into the evaluation too, because that, again, we will pull in. The questions are replicated there. And last but not least, I just want to say thank you to our presenters, to our co-facilitators, Adenike for being our lead facilitator. We could not do this without all the family faculty and these amazing people that step in, and Allison and Mitra were in the main room, and of course my partner Meg Mo and our funders, and all of you actively helping us to think about how we do things differently and make change that matters the most. So thank you for being here. If anyone wants to get in touch with us, if you had any concerns, questions out of this is a sensitive topic. We'd love to hear from you so that we can make sure that you feel good about, and we can ensure that we're meeting what you need, and can address any of those if you did have any concerns coming out of today's conversation. Nikki and Michelle, anything in the last minute that you would like to end us with and leave us thinking about? No pressure, but just in case you got anything.
Just a thanks from me for everybody's open participation. Thank you.
Yes, thank you so much, and keep asking questions, keep kind of questioning the structures of power. I really appreciate everyone's perspectives and expertise.
That was a fantastic way to end us, continuing with questioning the structures of power and really thinking about what that means, and doing that with partners with the families and providers and all of the practitioners that are represented here today. It's a really fantastic group. Thank you, everybody. Until next time, be well.